Hi, welcome to Black Health Now. I'm Brenda Aske from Biolumina, the anti-cancer agency that's part of the Omnicom Health Group. And I'm so excited to be here today speaking with Dr. Miriam Osei, who is a second-year hematology fellow at Dana-Farber Cancer Institute. Thank you so much for joining us.
Thank you so much, Brenda, for having me, and to the Black Health Now team and the Biolumina team also for having me talk about this important topic.
This is a tremendously important topic. Could you tell us a little bit more about how you became interested in Duffy Null status?
Yeah, so one of my motivating reasons for going into medicine to become a physician was to be able to address health disparities that affects individuals from minority backgrounds. And so during residency, I had the privilege of working with Dr. Lauren Merce, who this sort of Duffy Null project is actually her brainchild. But hearing for the first time about this Duffy Null variant and how common it is in people of African descent, but even though it's a normal variant, unfortunately, leading to health disparities that these patients face, got me very much interested in being a part of learning more about the variant, and then also advocating for changes in the medical system that would help reduce the disparities that individuals may end up facing.
Yes, I remember Dr. Merce speaking at ASH last year, and it made a big impact. I'm looking forward to talking again this year and making more progress and awareness of this. But first, let's level set for everyone here. So could you tell us what a neutrophil is and what does it do?
Yes, most definitely. So, our blood is made up of many types of blood cells. I think the one that a lot of people are more familiar with is the red blood cell, which sort of helps with carrying oxygen. But a neutrophil is actually a type of white blood cell and is very important in helping us to fight off infections. So a lot of infections tend to be caused by bacteria or pathogens. And so when there's a bacteria that is noticed in the bloodstream or in the body somewhere, neutrophils are the first ones that are activated to go to the location of the infection and to sort of kill off the bacteria hopefully even before it causes infections, and then even if it's causing infection, to sort of calm down the infection that has been triggered and help us to stay healthy. So very important part of our blood system.
This one is the first line of defense against infections for everyone.
Exactly.
And so, could you tell me a little bit about variability by race and what's driving that? Or actually, going back a little bit, is there variability in the definition of normal neutrophil counts?
Yes, so to address that question, let's talk a little bit about how neutrophils are measured. So neutrophils are, as mentioned, sort of they are floating around in the blood. And so the easiest way for us to measure neutrophil counts is by doing a blood draw. I think a lot of people have probably gotten a blood draw called a complete blood count. And the neutrophil count tends to be reflected in something called the absolute neutrophil count. Now, neutrophils are usually produced in the bone marrow, and it takes about 7 to 10 days for them to go from like tiny neutrophils to mature neutrophils where they can actually fight off infections. And then after maturation, the majority of the neutrophils, they either stay in the bone marrow or actually go to other places like the spleen and other tissues like the lungs and the liver. And so interestingly, only a small amount of neutrophils actually go into our blood, about 1 to 5%, I would say, and the remaining up to 95% are elsewhere. And the neutrophil level, the absolute neutrophil count, can also fluctuate over a matter of hours. It takes about 3 to 24 hours for a neutrophil to be in the bloodstream. And so the absolute neutrophil count tends to be a very brief snapshot of what is actually going on in the body's white blood cell count, and can easily fluctuate. So long story short, it tends to be an imperfect proxy for the total neutrophil count. And that's also one of the reasons why we see the variability in absolute neutrophil counts, even from one institution to the other. For example, in Boston, where I'm based, I have the privilege of working at 3 different institutions. One of them is the Dana-Farber Cancer Institute. And at the Dana-Farber Cancer Institute, the reference range for what is considered a normal neutrophil count is between 2,200 to 6,100. Whereas when I walk down across the street to Brigham and Women's Hospital, which is literally 1 block, takes me, let's say, 30 seconds to walk across the street or the bridge to get there. The neutrophil range, the normal neutrophil range is a little bit wider, and then also starts at a lower number at 1,900 compared to 2,200 at Dana-Farber. Then you can go a little bit further out to Boston Medical Center, which is another institution in the Boston area, about 20 minutes drive from the Dana-Farber and Brigham, without traffic. Of course, Boston traffic can be crazy, but even just 20 minutes, away, their reference range is also different, with an even slightly even lower limit of normal for their neutrophil count at 1,800. And then going up to 7,000.
Yeah, this is such a pretty big variation, even locally.
Exactly. And so one of the reasons we also sort of seeing a little bit of variation from institutions to institution is that when it comes to reference ranges, a reference range is thought of as where 95% of healthy individuals fall. And so if you fall below or above, the thought is that then there's a higher likelihood that you are considered non-healthy, essentially. And the establishment of the reference range by an institution is actually, I was surprised to find out that you just need 120 healthy individuals to be able to establish a new normal reference range. And then after that, you just need an additional 20 to 40 individuals to confirm and validate the reference range. And so these reference ranges essentially sort of reflect the individuals that end up coming to these institutions or living in the nearby institutions. So that's one of the reasons why we do see a little bit of slight variations from institution to institution.
Yeah, the definition of
then,
normal is not necessarily broad enough and
exactly.
inclusive enough.
Exactly, yeah. And then it's the differences is even more stark when we go to regional variations. So when you look at the sub-Saharan and then Middle Eastern part of the world, the absolute neutrophil count reference ranges are significantly different from what we see here in the US. And so, for example, we see that Kenya is starting as low as 1,000 and only goes as high as 4,000. Similar with the UAE. And then even Togo, it's as low as 500 and just goes up to 5,400. So very significant variation by looking at the sub-Saharan continent compared to the US. And then even in the US, we've also noticed that there is, as I mentioned, at the institution, sort of from institution to institution, there is variability. But even when we look at some racial groups, there is some variability in the normal reference ranges where individuals who are self-identify as Black, interestingly, have a slightly lower absolute neutrophil counts compared to individuals that identify as white. But the even more interesting thing is that even though when Black individuals do have this lower neutrophil count, it's not associated with increased risk of infection or increased risk of death. Whereas when white individuals tend to have these lower numbers, it's more likely to be associated with a disease state. Yeah.
That's fascinating. So there's not a lot of correlation of this neutropenia level with actual clinical impact or relevance.
Exactly, Brenda.
And you were saying the snapshots are just one point in time too. So it seems like there's a lot of impreciseness happening.
Yes, exactly. And so that sort of begs the question of why is this the case? Especially, and that's what we were sort of interested in, understanding why is it that it seems like individuals who self-identify as Black. So why is there a sort of tracking with race? And it's important for us to keep in mind that race is a social construct and not a biological fact. There's actually a lot of studies have shown that there's actually more genetic variation within races than between races. So whenever we see patterns like this, it's important as a sort of medical community to try to understand, is there something more objective or more of a biological explanation for the variation that we're seeing, rather than saying this is because of race. And that's what brings us to the topic, for this session today, which is the Duffy Null variant, essentially. And so, the question is, what is a Duffy Null variant? But before going into what that exactly is, just wanted to stress how very important the Duffy Null variant is in Black individuals or those who are of African descent. So actually, up to 2/3 of Black individuals have this Duffy Null variant, and that translates to 27 million Americans, which is a lot. Out of the 2/3, about 25%, so essentially about a quarter, will have an absolute neutrophil count that is below 2,000, which is usually where the lower limit of normal for a lot of the already established reference ranges fall. And this translates to about 6.6 million Americans who are sort of being flagged as, oh, you have a lower than normal absolute neutrophil count. And then out of the 2/3, 10% will actually have an absolute neutrophil count that is below 1,500, which is usually when providers like sort of red flags go up to say, oh, is there something wrong? And that translates to 2.7 million healthy Americans ending up getting the diagnosis of neutropenia, which is essentially saying the neutrophil count is below way below the normal range, and therefore concerning for some sort of disease state. Even though, again, like I said, this is happening in healthy individuals who sort of self-identify as Black.
Yeah, that's a lot of people who are flagged for intensive evaluation or follow-up or concern. They may be worried if they see this diagnosis, and it's all for nothing. It's all a kind of a mischaracterization.
Exactly. And that's sort of how it feeds into health disparities, which we'll be getting into a bit more shortly. Mhm.
I think you wanted to talk about where the origin of the Duffy Null variant also.
Exactly. Yeah. The question is, why is it so common in individuals sort of African descent? And the reason why this is the case is because of the Duffy antigen's relationship with malaria. So taking a little bit of a step back, what even is, what do we mean by Duffy Null? So Duffy is actually an antigen marker, or someone would say, or a protein that is expressed on our red blood cells that we sort of inherit genetically from our parents. It's similar to the blood typing system, where we have people who are type A, type B, type O. So essentially, individuals who are considered type A blood, they express the A antigen on their blood cells. Those who are B express the B antigen on their blood cells, and so on and so forth. So the Duffy antigen is a minor antigen marker on these blood cells. For the Duffy antigen, it's either you express it or you don't. And if you express it, you have the Duffy antigen. If you don't, then it's considered a Duffy Null, essentially. And both versions are just variants. It doesn't necessarily mean that there's any disease pathology going on. It's just either you have it or not, and it's just a normal variation. Now the reason why the Duffy sort of null variant is very common in the sub-Saharan continent is because the malaria parasite actually uses the Duffy antigen on the red blood cell to enter blood cells and cause disease. So what ended up happening ages and ages ago is that someone, developed this variant whereby they didn't have the Duffy antigen. And because of that, it was more difficult for malaria parasites to infect them and cause disease. So then that individual ended up surviving into adulthood and having children, more children, and their children, and passing on this variant to their kids. And their kids, because they have the Duffy Null variant, are also less prone to malaria infection. And then they also end up living longer and having children and sort of passing on the Duffy Null variant. And so essentially the pressure of malaria in the sub-Saharan continents sort of led to a selection for the Duffy Null variant. And that's why we see it very commonly in individuals of African descent in the United States here also.
Yeah, so it's an adaptation of evolution that created this resistance to malaria, and it's an advantage. But now
Exactly.
now it's a flag on charts on occasion.
Exactly. Yeah, it's impressive the impact malaria has had on the on the African continent, because there are other examples like sickle cell disease, where because of malaria it's very common in people of African descent too.
Yes, yes. So what tell us a little bit more about why an accurate assessment of high or low counts is important. I dive into a few more examples of that.
Yeah, no, definitely. And so like I mentioned, the Duffy antigen is expressed on red blood cells. So the question is, so someone probably is wondering, what does that got to do with white blood cells? Because I just said at the beginning, white blood cells are different from red blood cells, sort of have different function.
Mhm.
And this is because the Duffy antigen has multiple roles in our body. It's actually important in regulating chemokines, which are, I'll say, they are like chemical signals that are sent out into the body. And so the Duffy antigen essentially releases these signals that encourage neutrophils to migrate from the bone marrow and other parts of the body into the bloodstream. So for individuals who have the Duffy Null variant, this signal is not as strong, essentially. And so they end up with fewer neutrophils in the bloodstream. And most of their neutrophils sort of more so hanging out in the bone marrow or in other places like the spleen. And this is totally normal, even though it looks like the absolute neutrophil counts when you do a blood draw looks low. It's totally normal. Multiple studies have shown that when these individuals get an infection, they are able to mount a very robust immune response. And sort of as we saw earlier, they don't necessarily, it doesn't correlate with mortality. And so the whole body absolute neutrophil count is still normal. It's just that because the blood draw we do is just a snapshot and imperfect, it looks like they have lower than usual white blood cell counts. And so that's sort of how the Duffy Null variant impacts absolute neutrophil count. And to your question about, what is the impact of mischaracterizing neutrophil counts? So we talked earlier, Brenda, about race being a social construct. Now, systemic racism is essentially embedded structures and entrenched practices that expose individuals, mostly from minority groups, to health harming conditions and impose barriers to opportunities that promotes good health. So in case of the Duffy, sort of like the Duffy Null variant, even though, as I mentioned, it's normal, there's nothing wrong with individuals who have this variation, and it's a clinically, even though the absolute neutrophil count looks, lower than our established reference ranges, and it's clinically insignificant, because of how the medical system sort of handles individuals who have lower absolute neutrophil counts. It ends up actually causing iatrogenic harm and propagating systemic racism. So that as an example, as you sort of put up on the slides, many individuals who self-identify as Black would have this Duffy Null variant, and maybe they go get a blood test done by their primary care doctor, which it comes back, their absolute neutrophil count looks lower than the established reference ranges, because a lot of times these established reference ranges unfortunately don't include, individuals from minority backgrounds, and then also don't sort of like factor in the Duffy Null variant. And so patients get flagged as, oh, your white blood cell count is low. The primary care doctor, keep in mind, these are individuals who have no other reason to be concerned for a low white blood cell count. So they are healthy, they don't have an increased risk of infections. They haven't had to be hospitalized multiple times for infections in the past. They got a blood count for some other reason. Maybe they were going to go do some sort of like minor ankle surgery for sprained ankle or something like that. So no other concerning reason to think they would have a condition that makes their, a medical condition that makes their white blood cell count low. So essentially, the primary care doctor sees this, and then because it's low, refers them to a hematologist. Usually hematologists are part of cancer institutes. And so, patient sees, I'm referred to a hematologist at a cancer institute. Oh my gosh, do I have cancer? And so that comes with a lot of like emotional stress and turmoil, sort of just like being referred to a specialist that works at a cancer institute. The other thing too is that when this is noticed, additional testing tends to be done, which ends up taking time and resources, from individuals. And one of the more common tests that tends to be done is a bone marrow biopsy, which is, it's a little bit requires a little bit more to do than a simple blood test. And studies have actually shown that for individuals who self-identify as Black, who are flagged as having low white blood cell counts and have like no other concerning symptoms or reason to think this is because of an illness, when they do end up getting a bone marrow biopsy, 95%, that is almost essentially almost everybody, ends up having a normal bone marrow biopsy. They don't see anything abnormal in the bone marrow biopsy. And then 60% of them end up being told, oh, you just have a low white blood cell count and it's not significant clinically, so go on living your life. But then they've sort of had all these weeks or months of waiting to do the bone marrow biopsy, resources taken away from them, time taken away from them, just to be told this is actually not that big of a deal. And actually, yeah, exactly. And even
It's
in
truly remarkable. It's so painful and such a burden to go through this process to get a bone marrow biopsy.
Exactly. And then it's even been shown for people who, so instead of sort of going to do this bone marrow biopsy, and I said there are additional testing too that can be done that tends to be expensive and time consuming and takes time to return. So patients are sort of waiting in angst, essentially. But essentially, instead of like jumping to these testing, if patients are just tested for the Duffy Null variant and it comes back looking that is what it is, then you can just reassure a patient that, oh, this is actually a normal variation of your white blood cell count and not something to be concerned about. And there's been a study that did show that for patients who like Black patients who did get a bone marrow biopsy for just their white blood cell count being low, 97% of those individuals had the Duffy Null phenotype. And so very, very high and very, very common, and therefore important to consider this when you have, for providers, when you have a Black patient who happens to have no other reason to have a low white blood cell count, nothing concerning, to think about testing for the Duffy Null variant, just because of how common it is in people
Yeah.
of African descent.
I imagine you could, the Duffy Null test is a simple blood test, which is a lot more or a lot less labor intensive than the workup in a bone marrow biopsy.
Exactly. Yeah, and then there are other ways too that we see systemic racism at play. When we don't, like as a medical community, we don't think about the Duffy Null variant, just being a normal variant amongst individuals of African descent. And so one of them has to do with clinical trials. So a lot of our clinical trials have like requirements or criteria for people to be able to enroll in the clinical trials. And one of them tends to be your absolute neutrophil count. And a lot of times, unfortunately, the criteria don't keep in mind that, the Duffy Null variants and try to sort of like create a reference range or at least make some caveats for that. So what ends up happening is individuals who have the Duffy Null variant, which ends up being more individuals who are who self-identify as Black, end up being not able to meet the inclusion criteria to participate in these research studies. And then unfortunately, that sort of leads to them being eliminated. And then we don't know what what happens with all these drugs and trials that we're doing when it comes to individuals who self-identify as Black, and it sort of just keeps propagating systemic racism in that regard.
Yeah,
Additional
I know that.
to, yeah, go ahead.
FDA is working really hard to get representation in the clinical trial so that we do have that information about how it works in everyone. But to have this neutrophil count as an exclusion factor for trials, you don't have the innovation, you don't have the information. It is a tremendous barrier to care.
Very much so, definitely. Yeah, and then when it comes to medications, so
Oh,
for
yes.
example, some rheumatologic conditions require medications that end up suppressing the white blood cell count in everybody, not just, you know, people with Duffy Null variants, or for example, chemotherapy medications also suppress the white blood cell count. So when it comes to these medications, there are cutoffs. At a certain point, if the blood count drops below a certain point, the drug insert may say reduce the dose by half, or stop the dose and wait and see what happens. So what in these scenarios, for people who have the Duffy Null variant whose white blood cell count will be on the low, would look like they are lower anyway to begin with, it will be very easy for them to get to the point where the drug insert says stop the medication or reduce the medication. And so they end up not necessarily getting like full dose medication and sort of like the full effect of medications and treatments as they should. And that also is another way that unfortunately leads to barriers for patients getting good care in the setting when it comes to the Duffy Null variant.
Oh, yeah, that's hugely impactful. It seems like there needs to be so much more education. And what changes are in progress for gaining understanding of Duffy Null and better testing and all the things that will improve care?
Yeah. So there's still a lot to be done, but I would say that there's a lot that's been done over the past few years, especially as mentioned earlier by Dr. Lauren Mertz, through her initiative and the initiatives of our team here on the Brigham side. And so one of the things we thought was important to sort of first address was to change the medical lingo surrounding the Duffy Null variant. And so in the past, individuals who self-identify as Black and have a low white blood cell count than the established reference ranges were termed to have benign ethnic neutropenia. The word ethnic, as mentioned, race a social construct. So it's like, what does that even mean? Who knows? And then the fact that there's the word neutropenia, which indicates a disease state, like there's something wrong, we felt like was something that needed to be changed. And so we've advocated, and this has been sort of approved by like the medical societies, American Society of Hematology in particular, for changing the terminology to Duffy Null associated neutrophil counts. And so we sort of are eliminating the ambiguity that comes with ethnic and race and pointing more towards the biological reason for the neutrophil counts. And then also, instead of saying neutropenia to indicate it's a disease state, we have advocated for it to say, associate a neutrophil count that's associated with the Duffy Null status, essentially. And so that also takes away this sort of pathologizing of this normal variant or normal condition, which I think is very helpful for when providers are sort of reading patients' charts, not jumping to, there must be some issue with this patient that I need to figure out what's going on, versus if they see, okay, this is just a normal variant related with the Duffy Null antigen, notes that in my brain, and then sort of like focus on other things that for the other reasons why the patient is here to see me. So that's been a huge plus within the medical society, being able to change the terminology. And along with that too, just this past October, we're able to get ICD-10 codes that reflect the Duffy Null associated neutrophil counts. And so, yeah, which is great. Essentially, this will, and this is something that can follow patients wherever they go, so that the patient doesn't need to sort of re-explain hey, I have, yes, my neutrophil count looks lower than your normal, but it's because I have this Duffy Null variant, and it's a totally normal variant for me. But then providers can easily like look into patient charts and be able to pull these ICD-10 codes to explain why patients have this have the normal variation in their white blood cell counts. One of the other things that we worked on and have been successful with at our institution, at least, and then we are having that expanded to other institutions, is to reevaluate absolute neutrophil count reference ranges by the Duffy status. And so we did a study. As I mentioned, you need like 120 healthy individuals to be able to create a new reference range. And so we essentially had healthy individuals who self-identified as Black come in and sort of do testing for the Duffy Null status. And then based on their neutrophil count, for those who had the Duffy Null status, we were able to come up with a reference range for the absolute neutrophil count. That is not surprisingly, it is a little bit lower than our institution's absolute neutrophil counts reference range. But now if an individual sort of presents with a low white blood cell count at our institution, there's a note that says, this is the reference range for those with a Duffy Null phenotype. And so providers can sort of test for the Duffy Null status, and if they are Duffy Null, then they can say, okay, they are still within what we'll consider normal reference range for Duffy Null status, and there's no other reason for us to be concerned to go digging deeper into why their white blood cell count is on the it sort of like falls below what we've already established beforehand. So that's been a big change at our institution. And the American Society of Hematology is working with, I believe, about 24 other institutions across the United States to also establish reference ranges for individuals who have the Duffy Null phenotype, and then also even looking at pediatric reference ranges to sort of help.
Oh, excellent.
Also, because within the pediatric population, for those who have the Duffy Null phenotype, it's actually their white blood cell count is actually looks even lower than when you compare it to adults. And so that's something that is at work currently there too. And then also, working with, more from the provider perspective, working with blood banks to make it easier to get testing for the Duffy Null phenotype. So it wasn't the easiest test to get done at our institution before, but it's getting better. And so one of the initiatives with the American Society of Hematology is also to sort of help encourage blood banks to make it a little bit easier to test for this phenotype, essentially.
Wow, that's a lot. I think the depathologizing is such an important point, and using the right language, that it's a count, the ICD-10 code, the flag to say, this is my status and this is normal. That prevents a lot of unnecessary workup. And what hits me most emotionally is thinking about the pediatric patients who might be perceived as having a pathologic neutropenia, and all the workup and the stress on the family and the stress on the child. Wow, what a big impact that you're having.
Exactly, yeah, and that's definitely one of the reasons why we've sort of made sure to try to include what is going on in pediatrics too, not just adults also. And then I think it sounds like the audience is probably there's a decent number of scientists working, since Biolumina is a pharmaceutical company. But one other action item that individuals listening on the call who work with these companies can think about is when these companies are sort of conducting clinical trials to encourage them to consider, hey, maybe instead of just having one blanket reference range for everybody to be included or excluded, to use for inclusion or exclusion, let's think about having a reference range for individuals with a Duffy Null phenotype or variant, and then providing ways for providers to test for that when patients are interested in being a part of these clinical trials, and then also for the medications, probably encouraging studies to look at for individuals with a Duffy Null status, what what um what level what is their more appropriate lower limit lower level limits for us to consider sort of like either de-escalating or stopping a medication instead of just picking the lower limits of normal that's already been established based on individuals who don't necessarily have the Duffy Null variant. So that's definitely one other way that individuals on this call can think about sort of advocating to reduce the systemic racism that we've seen with the Duffy Null variant. And then also for patients who may be listening, to feel empowered to, if their doctor says, hey, your white blood cell count is low, go see a hematologist or a cancer doctor. They may do a bone marrow biopsy. And especially if you self-identify as Black, like mentioning, hey, have you heard about this, normal variant called the Duffy Null variant? Can we test for that first? Because there's really nothing else, going on with me that should make me concerned or should make someone concerned about some medical condition before we go down the rabbit hole of referrals, which take forever for people to get in for referrals, and then bone marrow biopsies, which can take some time to get done, and then not the most comfortable procedure to be done. So patients should feel empowered to mention the Duffy Null variant to their providers.
Yes, and bring some potential awareness and prevent all that. And yeah, for those of us who are involved, clients who in the pharma industry doing clinical trials, yeah, advocating for those changes and raising those questions, I think could make a tremendous difference in the world.
Yeah, no, definitely.
So I wanted thank you so much. I've learned so much about this. I know we have I want to acknowledge just the tremendous information and research that's kind of coming out of Dana-Farber, just advancing this field, advancing our understanding, and making care much more equitable for everyone. These
Yeah.
are
Yeah, thank you very much, Brenda, for the opportunity to share. Like I said, it's a team effort. Dr. Lauren Merce has sort of been leading the charge on this under the guidance of Dr. Maureen Achebe, who's a hematologist here at Dana-Farber and Brigham. And the whole Brigham hematology department has been very supportive. The American Society of Hematology, of course, has sort of taken this and escalated it to the national level, which has been great. And then having organizations like Biolumina and the Black Health Now components, sort of, hearing about these talks like these national meetings, and by then bringing it to individuals who may not necessarily have the ability to access these national meetings, so that patients can advocate for themselves, and we can all advocate in different avenues that we're in.
That we're empowered to be. Yes, thank you so much. Thank you to Black Health Now for hosting, and thank you so much, Dr. Osei. We so much appreciate you sharing your information and education, and thank you to everyone for listening and joining today.